Happy Friday, all. You'll notice a dramatic increase in enthusiasm now that we're recording. It's only for the, I'm kidding, it's not for the cameras, it's for you all. Welcome. We're just very mellow on the inside and then very, very excited for another Friday RLR. Prof Rez is on his way, I assume, from his morning report, which ends at 9, so it always takes a little while. We're very excited today for two reasons. One is we have one of our newest team members who is scribing for the first time. Gerardo, do you want to say hi and introduce yourself to the crowd?
Yes, well, hello, good morning, everyone. My name is Gerardo Luna, and I'm from Peru, and this is my first time scribing, so I'm very excited.
Well, we're very, very excited to have you. Tell us something about yourself, Gerardo. What would you say as your fun fact?
Um, well, a fun fact about me would be that I get obsessed like very often, but I use my ability to obsess to like do tasks, very challenging tasks, and so I use that in my advance, I would say.
Amazing, amazing. That's cool. What are you most obsessed with these days? VMR is what Francisco is suggesting.
Well, one of the things is definitely VMR, and other things I like to create schemas, like diagrams of the things that I learn in medicine now that I'm taking internal medicine, which is a course in the syllable. And I like to do schemas about different topics, like, for example, I don't know, nystagmus or ptosis or things like that. I like to explore the differential diagnosis.
That's so cool. Oh gosh. Yeah, you got to share your schemas with us. You really, really have to. Thank you.
I would love to share it.
Yeah, that sounds awesome. Thank you, Gerardo. I just want to give a shout out to Marino, who is now doing teaching points round number 1,400,000. Marino, if this case is about chest pain, you can be frustrated. It's okay. It's okay to be frustrated at 4 + 2 + 2. Do you want to reintroduce yourself to the crowd before we get going, Marino? I want to make sure everybody knows you here. It's about time.
Okay, so hello guys, my name is Marino. I'm from the Dominican Republic. For those who don't know me, I've been part of the team for around 2 months, I think now. So I'm very pleased to have taken this opportunity to grow and to meet awesome people in the team. So I love internal medicine, I love clinical reasoning, and I am striving to be a better physician every day by joining these daily morning reports. So if you want a fun fact about me, I have 4 cats and I take care of 10 more outside my house.
14, huh? 4 + 2 + 2 + something.
Yeah, also I take care of the dog of the gym I go to too, but he's getting older. He's like 14 years old. We don't know how old is he, but we always bring him food and he gladly takes it.
Oh, that's so cute. Oh my gosh. It sounds like you live vicariously amongst wonderful animals, huh? That's so cool.
Yeah.
Thank you. We also have our guest presenter today, and a big shout out to the case review committee, who has now over in less than 2 months had over 30 submissions. That's more than peer-reviewed journals, Amanda and Omaima. So a massive congratulations to you all, and thank you to the folks out there who are submitting their cases. Really love to hear them, and excited for our guest presenter, Mark. Mark, please, I know you've been to a few VMRs now. We'd love to have your voice out there. Tell us a little bit about yourself.
Yeah, hey everyone, I'm Mark. I'm one of the third-year internal medicine residents at UPenn. I'm from Southern New Jersey, and I went to med school at Cooper Med School in Camden, New Jersey, and then now I'm at UPenn for residency. So I've been in Philadelphia for about 7 years now. My clinical interests are very similar to you, all of you guys: clinical reasoning, med ed, and then a focus also on like cognitive biases and clinical reasoning as well. I just thank you guys for the opportunity to present this case, and thank you for Noah for helping me put this together. This is one of my favorite cases of residency thus far.
Oh, what an honor! What an honor to meet somebody with similar interests and similar passions, and also to have the opportunity to reflect on their favorite case in residency. That's so cool. I think we should get going, and if Prof Rez manages to make it, we'll catch him up. So, Mark, please take it away.
Awesome. All right. So for our patient, so he's a 59-year-old male, and he's presenting to the ED with 4 to 5 weeks of bilateral lower extremity pain.
Gotcha. I'll just stop and reflect here, and I think that there's two things that are really important in this case. Is to first ask ourselves, what can cause extremity pain? What variables help us understand the bilateral nature of this and the fact that this is a young man? So in general, it's helpful to break down extremities just like we break down everything else. We break down the chest into cardiac, lung, esophageal, and chest wall. We break down the abdomen into 4 different quadrants. And I think it's helpful to break down the extremities into 4 different categories. And those categories that I find helpful are 1, skin and soft tissue; 2, vascular; 3, osteoarticular; and 4, neuromuscular. Now, those are 4 ways to slice this approach, not because it's necessarily anatomical, but rather because it correlates significantly with what the findings on the physical exam are. So, for example, if you see a rash, you know that the skin and soft tissue compartment is involved. If you see edema or pulselessness, you know the vasculature is involved. If you see a joint effusion, or if you hear of pain on weight bearing, that involves the osteoarticular apparatus. And finally, if you hear of sensory abnormalities or weakness, that localizes to the neuromuscular apparatus. So with very few questions or physical exam observations, tremendous progress can be made about localizing the lesion that's causing lower extremity pain. So I think the initial temptation will be to actually immediately look at the legs while you're talking to the patient and merge and synthesize the dynamic HPI that the patient is sharing you with your observations. That's probably the most effective way to take care of this patient. And we may or may not do that because the whole format of VMR is to stretch our clinical reasoning. So we may not get that, and we'll be able to practice whatever way the data is coming to us. But I'll just share one really important observation, which is the problem of staring too much at the legs. Whenever you have a problem in the lower extremities, even if it's unilateral, you have to be open to the disease originating in the abdomen and going down into the legs. And the 2 most notorious examples of that are aortoiliac occlusion with subsequent vascular insufficiency in the legs, and of course, devastating neurological disease in the spine going down to the legs. So close scrutiny of the legs is important, but not to put our blinders on and assume the disease is in the legs, but to be open to the possibility that close exam of the body above the legs is going to be important as well. All right, Mark, tell us more, please.
Yes, already such a rich discussion. I just want to clarify. So this is a 59-year-old as well. I'm sorry if you couldn't hear me too well. So going further, so yeah, when I met him in the emergency room, he told me that, 4 to 5 weeks ago was this pain in addition to some numbness, swelling, and weakness. He essentially said 4 to 5 weeks ago, he woke up with these symptoms and they never occurred before. And he kind of told me that the numbness feeling that he had was in the entire leg, in the right leg, but below the knee, nothing above the knee. And then 1 week later, it moved, same exact symptoms, moved to the left leg. He had the left leg swelling, weakness, and numbness. And he kind of described to me that he was almost tripping over his feet. He also said that he was having some malaise and weight loss as well. He wasn't really able to quantify how much weight loss, but he told me he wasn't trying to lose weight. And really, he said, due to this progression of his pain and his inability to ambulate without a walker. He's never used a walker before. He came to, the emergency room for further evaluation.
Rez!
Good morning, good morning, good morning. How are you, Ravi?
Cruising along, my friend. Great to see you.
You as well. So this is, hi Mark, good morning to you, my friend. This, it's so easy for me to come and share my thoughts because whenever you get a chief concern, the first step is creating a framework. And look at that beautiful framework that Robbie created. It doesn't get easier than that. And then you just have to follow that framework to address this problem. Now, what's so interesting about this case is how often have you taken care of someone that has had migratory lower extremity symptoms? What Mark told us was that this started in the right leg and then it migrated to the left leg. And I'm assuming, Mark, is it still present in the right leg or has that resolved? It is still present in the right leg. Is that correct?
Yeah, still present in the right leg, and then the pain is just progressing in both extremities.
Okay, so this is really helpful. So now because right now we're trying to establish the right frame so we can solve this problem. And this isn't your typical bilateral lower extremity swelling. No, this is migratory lower extremity pain, swelling, and weakness. So of all of these, what do we tackle? Do we focus on the swelling? Do we focus on the tingling or numbness? Do we focus on the weakness? I will tell you personally, I'm open to the possibility that the swelling is so bad that it's compressing the nerves and causing discomfort. And therefore, I will activate the schema for lower extremity edema. But I do that cautiously. I do it very cautiously because a lot of patients who do have edema in their lower leg, it isn't truly a signature pain and weakness. So I have edema on one side, but on the other side, I actually am activating my neuropathy schema. And so for the edema schema, we've talked about a million times. Is it the heart, the liver, the kidney? Is it medications? Is it venous stasis? Is it something obstructing the lymphatics in the pelvis, for example? I want to focus more on the neuropathy and see if we can link it and explain the deal. Because the neuropathy to me is much more interesting and I think more diagnostically fruitful. I'll also love to hear Robbie's input once I share this, but what you're describing sounds like a peripheral neuropathy because the first thing you do when you're solving a neurologic problem is you either localize a lesion in the upper motor neuron or the lower motor neuron. There's no reason for us to be concerned for an upper motor neuron disease. There's no, paralysis, paresis, urinary retention, bowel incontinence. So we're in the peripheral nervous system. In the peripheral nervous system, there's mononeuropathy, but this isn't mono. We've already excluded that possibility because you have two extremities that are involved. You have polyneuropathy, but polyneuropathy is usually symmetric, involving both legs simultaneously. This actually brings to mind the less common of the three categories, which is mononeuritis multiplex. This is when you can get two nerves, two different nerve distributions that are involved in a non-contiguous pattern. So since I've highlighted that possibility, what's going to be really helpful is the physical exam, because I need to, I don't know yet whether to invest the cognitive effort in the edema or possible neuropathy. So I'm going to be paying close attention to the skin. I'm going to be paying close attention to the reflexes. And I'll just say one last, because I hate to just leave the frame like that. I think putting some diagnoses just onto the whiteboard is that, if you are dealing with the mononeuritis multiplex, this is when you get into the more inflammatory causes of nerve pathology, as opposed to the polyneuropathies where you're dealing with more B12 deficiency, diabetes, alcohol, and such. Robbie, I would love to hear your thoughts here too, because I remember your case of that patient with amyloid that presented with lower extremity edema, numbness, and the edema was so severe that it blocked off the arterial flow to the legs, and the patient had a lot of pain and discomfort. You had to just raise the leg, and all of a sudden you got the Dopplers working. But what are your thoughts here? I think the exam is going to be really fruitful for us to make more progress.
No, I completely agree with you, Prof. I love that inference and the leap to like a very rare possibility with these very odd and unusual combination of symptoms. And, you know, for me, I'm just like, I'm almost creating two separate patients, like one whose legs are just swollen and the one person whose legs are weak and who are having sensory symptoms. And of course, they could be related, like as you said, the venous compression is causing some nerve symptoms, but there's no immediate explanation that I can come up with that that explains all three, except maybe some bilateral patellar or posterior knee based compression that compresses everything. So it's like solving what causes edema and then solving what causes the neuropathy separately and trying to see if they overlap. And so I agree with you. It's almost like if you just remove the edema for a second, you're like, wait, you had numbness and weakness in the right leg, and then it moved over to the left leg. That's mononeuritis multiplex until proven otherwise. And maybe the edema is because you have glomerulonephritis or kidney involvement or whatnot. Like, who knows? Yeah, so I completely agree with you. I think the neuropathic symptoms are the most interesting thing. And I would follow them, but they may be as simple as this person has severe bilateral DVTs and has phlegmasia physiology or whatnot. So I think my mind is separating them, and we'll see if we can tie them together. All right, Mark, tell us more.
Awesome, such a wonderful discussion. So kind of going into some of his background data. So as far as his past medical history, so he has a history of hypertension. He also has a history recently of epididymoorchitis. So this essentially was diagnosed about a month and a half ago. He was having some groin pain, and then his primary care doctor ordered an ultrasound, which showed these findings. And then at the time, he also got a urinalysis and then STI testing, which were both negative. He also actually recently had an episode of colitis. He went to a neighboring hospital as an emergency department for this pain that he was having in his lower extremities, and they got CT scans, and this showed sigmoid and descending colon colitis. And that kind of just or I should say he wasn't having diarrhea, and they got some stool studies which were negative at that time. And then 3 months prior to presentation, he had COVID, just received Paxlovid, and it was kind of, you know, an uncomplicated course. In terms of the meds that he's on fluticasone for allergies. He's on lisinopril for his high blood pressure. And then at the outside hospital emergency room, he was prescribed oxycodone, pregabalin, and tramadol for this lower extremity pain that he was having. And then he was also prescribed pantoprazole when he was found to have this colitis. In terms of his allergies, no known drug allergies, and no prior surgeries. Family history, really just notable that his mother had alcohol use disorder. And in terms of his social history, he denied alcohol use. He smoked 2 packs per day of cigarettes for the last 20 years. He had a remote history of intravenous drug use. This was about 40 years ago, but denies current intravenous drug use. And he lived in Southern New Jersey and no recent travel.
Ooh, very, very intriguing. There's so many itises there, Mark, and it's hard not to wonder whether the itises might be related to an itis that's going on in the legs. And I'll just share something that we actually see quite commonly in a emergency room that takes care of predominantly older men, epididymoorchitis. And I think the first thing whenever you're dealing with any testicular pain is to ask the question. Two questions help you tremendously. Is it unilateral or bilateral? And the most common cause of unilateral testicular pain are either epididymoorchitis, an inguinal hernia, or the most morbid would be torsion. So when you have unilateral testicular pain, the first step is to make sure that there isn't a hernia. The next step is to evaluate the testes for torsion with your exam and an ultrasound. And finally, the diagnosis of epididymoorchitis is entertained. If, however, you have bilateral testicular pain, that becomes incredibly interesting, though the most common cause of bilateral testicular pain is actually heart failure with passive congestion into both testes, though, of course, you can have some scary things like Fournier's gangrene. So the key question of unilateral versus bilateral is very helpful. You can see how it shifts the calculus from torsion, epididymitis, hernia to heart failure, Fournier's, and some other things like drug reactions and angioedema. But the other really important question is this testicular pain that is referred to the testes, or is this testicular pain with palpation of the testes? Because the sheer number of things that can refer to the testes is very, very high. As Prof. Rez will tell you, we discussed a case on RLR a long, long time ago of a patient who had bilateral testicular pain from retroperitoneal Mets, referring the pain and by the testicular nerve. So the retroperitoneum is really important to think about in patients with bilateral exam negative testicular pain. And the stuff in the retroperitoneum can be nerve compression, or it can be vascular disease in the retroperitoneum. Now, why is the retroperitoneum jumping out? It's because you're telling us that there is disease in the retroperitoneum in the form of colitis. And so I'm really intrigued to see if the colitis and orchitis are linked anatomically by their coexistence in the retroperitoneum. So the one clarifying question I have for you is if you happen to know if the orchitis was unilateral or bilateral. Do you know?
It was bilateral.
Bilateral. Okay, that's super rare, super unusual. And if you move from the schema of infectious orchitis, irritant orchitis, or immune orchitis, the bilaterality is unusual for infectious or epididymal orchitis. Prof. Rez, any other thoughts you have?
Nada. Thank you.
Okay, so now I'll move on to the physical exam. So the patient vital signs, he was afebrile, normal blood pressure, normal pulse, and satting well in room air. Generally, he was pretty well appearing, no acute distress, nothing really notable on his HENT exam, cardiac exam, pulmonary exam, or abdominal exam, but really focusing on his neurological exam here. So he was AOA ×3. His cranial nerves were completely intact. His strength in the upper extremities was 5 out of 5. And then in his lower extremities, he had 2 out of 5 strength on right dorsiflexion and eversion, and then 3 out of 5 strength on left dorsiflexion and eversion. And his sensation to light touch was decreased on the right lateral leg and the right dorsum foot, and then also his decrease on the left side on the left lateral leg and the left dorsum of the foot. And then he also had 1+ Achilles reflexes bilaterally. And then also focus on his extremities and his skin. He did have like 1+ pitting edema bilaterally, or I should say non-pitting, sorry about that. And then he also had these few scattered follicular red papules on his legs that were about probably 2 millimeters in size that were non-blanchable. That the patient didn't report, he didn't notice, but when I looked at his legs, I kind of asked him about it and he said he never noticed them.
Boy, now we can actually make some progress finally in this case. Rabih, maybe what I can do is talk about just the neurologic findings and then leave the skin findings for you to tie in, if that's okay. The neurologic findings are really interesting. If you asked me a year or two ago to interpret these, I wouldn't really have much to discuss. But having spent 15 hours creating a schema on foot drop with Aaron Berkowitz, there's a lot that we can discuss now. What I want everyone to do is the following: look at your toes and take it to your nose. So toes to the nose, toes to the nose. This is literally your dorsiflexing, toes to the nose. And then I want you to look at your feet, and in your right foot, evert it outward. So evert the right foot outwards, and then with the right foot, take the toes to the nose. The function for this to happen is a peroneal. And the way I remember that is PED, like P, peroneal is involved in eversion and dorsiflexion. So I can tell you right now that there is some kind of disturbance of the nerves to the lower extremities that's impairing the function of the peroneal nerve. Now the question becomes, is the disturbance at the lower end of the peroneal nerve, or is it coming all the way from the lumbar region and then the contributory nerves? And then is a lesion, could it be somewhere higher up? And the way you can make progress on that is based on where the numbness is. So if it's just numbness in the lateral nerve, and if it's just impairment of the dorsiflexion and eversion, then probably the lesion is at the peroneal nerve. And if you ever wondered what that feels like, who has sat on the toilet longer than they should have? Scrolling through their TikTok? I know Robbie for sure. What happened? You could literally compress the sciatic nerve. So when you get up to walk, you're like, I can't move my foot. And it's like this weird sensation, but that's basically the sciatic nerve is eventually becomes the peroneal and the tibial nerve. So you experience that, or if you're sitting cross-legged and you have compression on that lateral aspect of the peroneal, so the leg that you cross over, you can get a foot drop. So this is what I'll tell you right now. I have zero doubt that this patient is having pathology of that peroneal nerve. Now the question becomes why, and can we use the other clues to advance as to the etiology, because it's not the common cause of just trauma. This is bilateral, it's migratory, so it's something more exotic than that.
I completely agree with you, Prof. Rez, and I honestly think that your initial reflection to call this mononeuritis multiplex from the very get-go is bearing fruit, because the patient has a combination of neuropathy plus skin. And the reason I say that is I'm not an expert in the assessment of skin lesions agnostically, but I think we can make a lot of progress in saying what causes neuropathy and skin lesions. And I'd say if you look at all comers, and you say the patient has rash over the areas where they have neuropathy, and they have neuropathy, the first thought that comes to mind globally is leprosy. And I think you have to consider that. And guess where leprosy tends to go? If it's gonna go anywhere beyond the skin, it's gonna invade the nerves and invade the testes. Why the testes? Is because leprosy loves cooler temperature. That's why it stays. I feel like I'm giving a Prof. Rez kind of pearl here. It feels so nice to talk about like cool pathophysiological stuff. So maybe I can try to mirror Prof. Rez energy. So leprosy exists in the skin because of its like biological structure. I can't even do it. Leprosy loves cold temperature. That's all I know. And so that's why if it does disseminate beyond the skin and the nerves, it actually goes to the testes. But here, knowing where Mark practices, I think knowing that the local epidemiology of leprosy is much less common. And so we should probably move away from that. But if you present this case anywhere else in the world, leprosy would be your leading thought. But there are two other broad categories of conditions, one of which is vascular disease, so vasculitis of the nerve causing vasculitis of the skin. You may wonder, wait, Robbie, no, this is not the typical lesion of vasculitis on the skin, and you're correct. The typical vasculitis lesion on the skin that we talk about all the time is palpable purpura. However, that is when we're talking about small vessel vasculitis. Medium vessel vasculitis shows up on the skin as well and has a very different skin manifestation. It causes, as Mark described, palpable, usually nodular lesions as a result of inflammation of the fat or paniculitis, so it can cause nodules. It can cause ulcerations because of deeper ischemia eroding the skin, and it can cause livedo changes, either reticularis or racemosa. So I don't think you need to know that, but you need to know that when we talk about vasculitis showing up on the skin, we usually are a little bit less precise in our language. What we mean to say is how small vessel vasculitis shows up on the skin. And the way small vessel vasculitis is those tiny capillaries bleed and you can feel them, palpable purpura. Medium vessel vasculitis is very, very different. Okay, so the big categories: infection, leprosy, vasculitis, and the last one is actually nutritional, with vitamin C deficiency, a notorious cause of perifollicular changes, and also probably not as a direct result of vitamin C, but as a result of the nutritional deficiency milieu. Patients can often have a neuropathy with it. So the combination of skin plus nerve, if they are related, I think would filter us down to those two possibilities. I actually do not have enough knowledge to confidently share with you a schema about follicular lesions without any filters. I don't have that knowledge, but I will try to accumulate that after this case. But applying the filter of nerve, that's the progress that I think we can make is infection, leprosy, vascular, really vasculitic, and then also entertaining nutritional deficiencies. All right, Mark, tell us more, please.
All right, now I'll move on to some basic labs and some imaging. So we got some emission labs. His BMP was notable for a creatinine of 0.95, which was around his baseline, a BUN of 12, a sodium of 133, a potassium of 4.2, a chloride of 100, a bicarb of 28, and a calcium of 8.2. He also had a CBC with a white blood cell count of 9.2, a hemoglobin of 12.9, and platelet count of 180. He had LFTs that showed an ALT of 72, an AST of 65, an ALK phos of 93, and a total bilirubin of 0.5. He also had an ESR, which was 17, a TSH, which was 1.04, and a CK, which was 43. And in terms of like basic imaging, he had an MRI of the brain that essentially just showed no restricted diffusion and otherwise unremarkable. And then he also had an MRI of the lumbar spine, and I'll just say the reading, that it showed transitional lumbosacral anatomy, mild multi-level lumbar spondylosis with no more than mild spinal canal stenosis or foraminal narrowing. And that's the end of this aliquot.
Professor, I'll just reflect on the neuro stuff and pass the mic back to you. And I think that this is very, very helpful because, you know, whenever you have bilateral lower extremity symptoms, you really, really should query the possibility of a central cause. And I think as a non-expert in neurology, if you tell me somebody has abrupt bilateral lower extremity neurologic findings, I don't think I, in real life, have accumulated the expertise to be confident that that is actually peripheral nervous system. Of course, the textbook would tell you that if the patient has a distal predominant weakness, if there are low reflexes, that should be peripheral. But if I were practicing by myself, I don't think I've accumulated enough confidence in the exam alone to be like abrupt onset bilateral leg is not cord, is not cauda, is not brain. But I think the MRI findings here further reinforce Prof. Rez's original hypothesis that this is in fact a peripheral nervous system issue. But I think you're seeing that people are saying, no matter what we find or say, bilateral lower extremity symptoms with very abrupt onset in a short period of time should have a degree of scrutiny for ruling out a central cause. And I think that is really, really helpful. All right, Prof. Rez, mic to you, friend.
That is beautiful, Robbie. And Mark, can I ask you, what was the creatinine?
The creatinine was 0.95, which was at the patient's baseline. And I think I might have forgot to mention, he also had a urinalysis, which was completely bland.
Okay, those are really important points, because whenever you're concerned for a vasculitis, especially, you know, small vessel vasculitis, you have to ask the question, is there a signature anywhere else in the body in the form of proteinuria or rapidly progressive glomerulonephritis, in the form of possible hemoptysis in the lung? You'd have a low threshold to get an X-ray or image at such patients when you're concerned for vasculitis. But what's so fascinating here is that we have no evidence of inflammation by some of the most sensitive parameters, and that's the ESR and CRP. Because when corrected for the age, this patient's ESR is totally normal. So my brain now is a non-inflammatory mononeuritis multiplex with perifollicular hemorrhagic lesion with no other systemic finding of vasculitis, at least no renal evidence, no pulmonary evidence, The GI is interesting because we know we have this history of colitis, but generally when you have ischemic colitis, you don't have diarrhea, you may have hematochezia and blood per rectum. So where I am is I am activating that DDX for vasculitis and vasculitis mimickers. Whenever you're thinking about vasculitis involving the length-dependent, gravity-dependent extremities, you really have to think about immune complement mediated versus non-immune complement mediated, meaning immune complex formation versus non. So the complement level would be helpful in this patient. To give you some examples, like endocarditis, lupus, cryoglobulinemic vasculitis, all of those would consume complement, but stuff like IgA won't necessarily consume complement. And recently I learned this, I don't know if it was from who, maybe from Rabih, but if the complement levels are normal, it doesn't rule out an immune complex mediated process, but if they're low, it prioritizes that. And then if you ask the question, what else can mimic vasculitis? It's really vasculopathy. And in vasculopathy, you're left with amyloid, and the amyloid that really likes to mimic this would be AL amyloid, not transthyretin amyloid, and not AA amyloid. You're left with vitamin C deficiency as a possibility, and in elderly it would be senile purpura. So Rabih, where I am, I think AL amyloid has a really good tropism for nerves and vessels, but odd that the protein was totally bland. I would still send the serum-free light chains and the SPEP and UPEP. I would get a better dietary history because I think vitamin C deficiency is a vasculopathy that can mimic these small vessel vasculitides. And I think your point about leprosy is such a phenomenal point. I really love that, especially in the right epidemiology. As the most common cause of polyneuropathy worldwide is leprosy. We often neglect to consider it. But I want to pass the mic back to you, Rabih, to see, like, where would you go next in addition to like the light chains, the vitamin C, like dietary history?
Yeah, Prof. Rez, I'm locked in right there with you. And honestly, I wasn't there when you said mononeuritis multiplex, but I think this case is so strongly mononeuritis multiplex, and mononeuritis multiplex is so strongly vasculitis. And so if you're developing a growth in vasculitis, you'll immediately hit a bump when you say, wait, hold on, there's vasculitis. I'm saying the word vasculitis, but the creatinine is normal, the UA is normal, and there is no purpura. And this goes to show you why the bigger vessels are actually much harder to diagnose. I mean, think about how hard it is to diagnose giant cell arteritis. We've all either going to or have missed a case. It makes it into so many CPSs. And similarly, medium vessel vasculitis is very, very hard to diagnose because the level of inflammation is far from the target organ. So if we are invoking a medium vessel vasculitis, which we would only be doing based on the fact that the extremity shows nodules and not purpura, then we would say, oh, but I don't expect that to cause a glomerulonephritis because the capillaries are too small to be affected by a medium vessel vasculitis. So for me, I'm very, very primed by the strong association of medium vessel vasculitis and nodules and medium vessel vasculitis and bilateral orchitis. And I would probably take that lead to scrutinize the AST, ALT more and say, wait, is this those liver enzymes hepatitis B, and could this person have hepatitis B associated PAN? But yeah, I think Prof. Rez, the learning for me is the re-emphasis on how medium vessel vasculitis is sneaky, often easily overlooked because the teaching on vasculitis is so small vessel dominant because it's so cool and characteristic, bleeding in the skin, bleeding in the kidney, bleeding in the lungs. So for me, what would I do next? Gosh, I think, I don't know what I would do next. I think I would look at that hepatitis stuff. And I think, I don't know if a nerve biopsy or a skin or a skin biopsy would be helpful, but I worry that this is the case that will go on and on and on and on. And the test that would ultimately really be needed for the hypothesis of medium vessel vasculitis is an invasive angiography, which is probably too soon to pursue that now, but it's hard not to think about it with just the constellation of unusual things: bilateral orchitis, colitis without, as you said, diarrhea, favoring ischemia, and then mononeuritis multiplex, nodules. When you look at it in some ways, it's the case is building momentum in that direction.
You know, Robbie, when you mentioned that, I think we've been talking about this a lot recently, like having the right brain, the right problem. Because if you frame it as mononeuritis multiplex, then all of a sudden nutritional deficiency is really out the window. And now you're really thinking, and just to show people like the power of a schema that we created with Aaron Berkowitz, like just putting that frame that Robbie put, mononeuritis multiplex, it really puts you into these buckets of diseases. And if you're like, which one of these can potentially explain, like you could Hep C and cryoglobule anemic vasculitis, but no kid makes that unlikely. And the findings on skin isn't really consistent with like HIV and Lyme. But I think where we are right now is either this vasculitis of variable vessel, which polyarteritis nodosa is probably the prototypical example, versus like an AL amyloid or like a lymphoma that could be invading, you know, different organ systems. I just find it very helpful to, hopefully we're solving the right problem, but then once you identify that problem, to just cross-check it with the schema that you've created from prior.
All right, Mark, hopefully we're solving the right problem. We have many recorded instances of us solving the wrong problem, so it wouldn't be a shock if we were, but tell us more, please.
Did you remember the time I forgot to even give you a problem to solve?
Yes, I do. Although I think that in terms of data deficiency, I have you beat with never telling you the age or gender of all the patients that, that I present to you, but
So this will be the last aliquot before I reveal the diagnosis. I'm going to start with one imaging test and then some advanced labs. So the patient got a CTA of the chest, abdomen, pelvis, which showed a small wedge-shaped hypoenhancing focus on the left lower renal pole, and then also a mild thickening in the aortic arch, extending into the origin of the left common carotid and left subclavian. So the patient had some additional lab work because of the elevated transaminases and the hepatocellular liver injury. He had hepatitis serology sent that showed a hepatitis B surface antigen that was positive, a hepatitis B DNA PCR that was 190 million, and a hepatitis B core antibody IgM that was reactive. He also had a hepatitis C antibody that was reactive. And then some additional labs that were sent. He had a Pianka and Cianca that were negative. He had an ANA that was positive to 1 to 40. He had complements C3 and C4, which are both normal. He had cryoglobulins, which were negative. He had a rheumatoid factor, which was negative. He had an anti-CCP antibody, which was negative. And then he had vitamin B1, B2, B6, and B12, and folate, which were normal. His HIV was non-reactive, and his A1C was 5.6. And the next aliquot will reveal the diagnosis.
Boy, I think that, Robbie, your hypothesis was spot on. It seems like we're dealing with acute Hep B, and we're dealing with what seems to be a disease that involves variable vessels. And so I think Hep B induced PAN would be a nice fit for this case. If I just run the DDX for aortic thickening and I convert that to aortitis, you have to make sure there isn't an infectious etiology here, specifically the S's like syphilis, strep, staph. But it would be hard to explain the mononeuritis multiplex. I would still like send the RPR for sure, because that could have cutaneous and nerve involvement. And if you go into the autoimmune bucket, like this isn't consistent with GCA, this presentation, because it wouldn't involve those medium vessel or Takayasos. So then you're left with like the variable vessel. And in the variable vessel, like I can't think of any of them that would cause what we're seeing here besides PAN. And then you have the Hep B that's positive. So that would be, I think, my final diagnosis, but based on what you said earlier, but curious to see what you think.
Yeah, Prof. Rez, I'm actually honestly kind of shocked that this person has hepatitis B because I'm just assuming epidemiological inferences from where I know Mark practices. Mark, can you tell us a little bit about the patient's background and any risk factors for this infection? Because the truth is, it's not super common in the US. So anything that led you to anything outside, of course, the liver enzymes and the syndrome that would put the patient at risk for Hep B?
Yeah, we talked to him for a while about this, and he did have the remote history 40 years ago of intravenous drug use, but besides that, no really recent risk factors for hepatitis B that he told us about.
Okay. And assuming the most common mode of transmission in the US is still maternal fetal, is there anything along that line of possibility, you think? No.
Not that the patient endorsed, no.
That's so interesting. Yeah, I think that honestly, I said that about liver enzymes, expecting the Hep B to be completely normal, because at this level, these kind of liver enzymes are so NOS, and idiopathic PAN is much more common than hepatitis B induced PAN. But yeah, Prof. Rez, I'm right there with you. I think that the momentum for PAN is, of course, the data that you analyzed, the Hep B positivity. But even if it was Hep B negative, I think the wedge-shaped renal infarct confirms the vascular nature. So if you start by saying mononeuritis multiplex is just a pattern, I haven't proven vascular nature. You start by saying colitis without diarrhea suggests ischemia, but I haven't proved that. Bilateral orchitis suggests vasculitis, but I haven't proven that. When you see a wedge-shaped infarct, now you can say this is a vessel problem, period. And a multifocal vessel problem can be a multifocal thrombotic problem. It can be an embolic problem, but the overlap of inflammation that this patient has suggests that it's a vasculitis. And so when you say what kinds of vasculitis affects these organs at the level they're being affected, because we know the skin is affected at a deep level, it's not purpura. We know that the kidneys are affected at a deeper level. It's not the glomerulus, it's bigger up, that this would be very suggestive of a medium vessel vasculitis. And if you just run the list, it's PAN, it's thromboangiitis obliterans, and Kawasaki's disease. The only good thing about medium vessel vasculitis is how narrow the DD hex is. The hard thing is just how hard it is to suspect it. It's so sneaky. It's right there in that sweet spot of being far enough from the actual organ that you really have a hard time detecting it. I'm right there with you, Prof. I think that would be my leading diagnosis. And I think the next step would probably be either organ biopsy or invasive angiography for classic microaneurysms view. Just as a knowledge nugget, the reason that I said organ biopsy with a little bit of hesitation is because the aneurysm formation in PAN portends a risk of bleeding with biopsy. So there tends to be a little bit of reluctance to do visceral biopsies because of the bleeding nature of this disease. All right, Mark, Mike, to you.
Awesome. And just to follow up on the Hep C positivity, because that came back a few days later, I just want to be authentic to the case. So that ended up being a false positive, and the viral load was negative. So rheumatology was consulted. I can't emphasize enough how excited rheumatology was about this consult. They recommended a right sural nerve biopsy, which was consistent with vasculitis and mononeuritis multiplex. And given all the clinical manifestations and labs, the rheumatologist, thought that the patient met clinical criteria for polyneuritis nodosa. Awesome discussion, guys.
Mark, absolutely incredible case. Prof. Rez, what do you think? What are your reflections at?
Honestly, I have two reflections. One is I think Mark presented this case as expertly as anyone could present a CPS case. So thank you, Mark, for the authenticity, the pause points. Like anticipating what we would say. Congratulations to you. And then, dude, Robbie, I love dancing with you, man. Like it was just so awesome to bounce ideas off of you and really anticipate like the diagnosis before it happened. If you see in the chat, I put a baboom because that's what it is, baby. We baboomed it today. How about you, Robbie?
Yeah, I'm a big fan now of these kinds of cases to do something that I think I do in my head afterwards, which is just to replay the key points, like the highlight reel, like the TikTok version of this 1 hour conversation. So my sural nerve falls asleep. And it's like translating the initial alquat to mononeuritis and multiplex, and then bilateral orchitis and colitis, and then hepatitis, and then wedge shape infarct. Like those, I think, are the key aspects of this case. And for me, I think the power of working as a team, because I remember my feelings after the initial alquat was like kind of foggy. I had no idea where this case is going. And as soon as you said mononeuritis multiplex, I was like, oh yeah, that's a really good thought. And then when bilateral orchitis plus mononeuritis multiplex is very, very much a pattern of medium vessel vasculitis. And so it was really cool. And I think on a small, very nerdy scale, it just illustrates the power of working together as a team. And not only is it just so much fun to be able to bounce off your thoughts and ideas off another person, it's just better, like objectively just better. So right back at you, Prof. Rez.
I just wanted to say really quickly, Roy, this reminds me of Denver, where it was fetal graft. So we were at Denver. It was like the craziest case in the world. I said erythroderma, and that prompted Robbie to be like, oh, this is like graft versus host disease, but I'm just not sure where the cause of it is. And it ended up being the first case ever of fetal graft versus host disease. It seems that Robbie has paused. So I'm going to pass the mic. Mark, maybe you can just comment on like what you loved about this case and then pass it to Marino to take us home.
Yeah, thank you so much. I just want to give an update how the patient is doing as well. So he's doing much better in terms of his neurological symptoms. The rheumatologist started him on azathioprine and prednisone. He's actually tapered off the prednisone, and now he's just on maintenance azathioprine with much improvement in his neurological symptoms, which is great. But this case really just highlighted for me just to always ask why. Like, why did this patient have colitis that was negative for infection, not consistent with the IBD? Why did this patient have orchitis with a negative STI screening, negative UA, right? Why did this patient have a renal infarct? And just, relating that to the mononeuritis multiplex really did land us nicely to medium vessel vasculitis, as you guys explained. So just continuing to ask why was a really big takeaway for me.
Mark, I froze real quick. I'm just so excited about this case. I've never seen PAN on VMR before. I'm curious, when you first inherited this patient, what did it, I was just really curious to like live vicariously. What did it feel like for you?
Yeah, I think the turning point for me was that when he had this foot drop on neurological exam, and then we imaged his neuroaxis, his brain, his lumbar spine, and it was totally normal. I was like, what can cause image negative, bilateral foot drop that is kind of presenting as a mononeuritis multiplex? And then finally, we saw the elevated transaminases. We're like, maybe this, what's in hepatitis serologies, they were positive, and then led us down that path. So really, I think the turning point for me was that negative imaging, and then kind of thinking back, could this be related to his orchitis, his colitis, his renal infarct? And, I feel like when so many organ systems are involved like this is like, one of the options definitely I think is, can a vessel be connecting, pathology of a vessel be, connecting all these organs? Absolutely
incredible. I just want the world to know what incredible work you're already doing in the space of clinical reasoning as an R3 now. And Mark has messaged me on Twitter and has such a force in the space of clinical reasoning, doing tremendous work with young learners in this space. And you have a great, bright future ahead of you, Mark. Really, really excited. I hope this is the first of many presentations on VMR. My screen froze, Prof. So I'm not sure if you already reflected. So please do if you haven't, and I'll pass the mic to. Oh, you got it. Okay. All right, Marino, please take us home. And I'm very happy for you. There's no chest pain today. Yes.
That's what I'm I was going to tell you that we got something different today. So let me take you through the teaching points, guys. So we had an amazing discussion on what an unexpected case, something really strange to see on VMR like this. So from the start, we got a patient that presented to the consult with lower extremity pain bilaterally. So a basic framework that Rabih told us was to think about lower extremity pain and divide it into, is it a skin or soft tissue problem? Is it a vascular problem? Is it an osteoarticular problem? Or is it a neuromuscular problem? So we can look simply with, just by looking the patient, we can kind of, or examining the patient real quick, we can kind of go into the direction of one of those buckets. So many clues that we can get is, for example, for skin and soft tissue problems, we need to look for skin changes. For vascular, we can look for pulselessness or changes in color too of the skin. In osteoarticular problems, we can look for problems with weight bearing or kind things going that way. And for neuromuscular problems, we can look for sensory abnormalities. And this patient did have sensory abnormalities, so later we went down on that road. So when problems are present also on the lower extremity, we must look out for diseases either in the abdominal region, either in the abdominal cavity or in the spine, as these diseases could translate into lower extremity edema and later pain. So examples for those are aortoiliac occlusion and neurologic disease in the spine. So another pearl that was shared is that sometimes even swelling of the extremities can cause pain because venous compression can limit arterial flow, and that flow can get stagnated and cause pain and also compress the nerves. So that's something we can rule out easily too. So in this patient, we were wondering what can cause edema in the lower extremities and also cause neuropathy. So this is when the Prof. Rez told us about the mononeuritis multiplex complex that consists in multiple individual nerves that are affected in multiple, in simultaneous or in sequence. So also later in the PMH of this patient, it was revealed that this patient had testicular pain and it was bilateral. So we must ask when patients get with testicular nerve, is it first unilateral or is it bilateral? So when we get unilateral testicular pain, we need to rule out hernias and torsion, and then we can go down the bucket of epididymal orchitis if all of those serologies are negative. If we get bilateral testicular pain, one of the most common causes is heart failure, but also we need to think about retroperitoneal disease compressing lymph nodes in the retroperitoneum. And this was a really big clue for this patient because he had unexplained colitis, and he could probably have had lymphadenopathy on the retroperitoneum, but luckily, at least he didn't have that. So in this patient, that in the physical exam, it was revealed that he had neuropathy affecting the peroneal nerve. And there is a really good mnemonic about how to learn peroneal and tibial nerve pathology. So for the peroneal nerve, we have the drop mnemonic. So the drop, the first part of drop stands for if the peroneal nerve has a lesion, you get foot drop. And the second P stands for peroneal, the E stands for evert, and the D stands for dorsiflexus. So for the tibial nerve, the mnemonic is tip toes. So tip means tibial inverts and plantar flexes, and toes means that you can't walk on your toes if you have a tibial nerve lesion. So that's the way I learned that during med school. So I could never forget it. So this patient had neuropathy and also skin lesions. So a quick PDS that we can get is we need to rule out leprosy, we need to rule out vascular disease, and also nutritional deficiencies such as vitamin C. In the chat, I saw that many people were going down the route of scurvy because of recent bias of cases. So scurvy could have been a great differential in this patient too. So this patient, we went down the route of the vascular disease. So because this patient had really severe skin changes, such as the palpable follicular lesions, and those were non-blanchable. But patients with medium vessel vasculitis can get a lot of different findings in the skin, such as palpable hemorrhagic lesions, livedo reticularis, and ulcerations. And in contrast to small vessel vasculitis that normally gets like small blanchable palpable purpura. So always in the setting of vasculitis, if you want to rule it out quickly or look for clues that can help you narrow down your differential diagnosis, you need to look for signs such of other organ involvements, such as hemoptysis, nasal ulcerations, hematuria, proteinuria. Look for the ESR and also look for the creatinine for kidney involvement. So in this patient that has inflammation, polyneuropathy, and vascular changes, those vascular changes were imaging positive, consisting of aortic thickening, wedge-shaped infra in the kidney, and also the skin changes that mostly suggest vasculitis. So specifically medium vessel vasculitis, and we need to look for those. So we need to rule out polyarteritis nodosa. Kawasaki disease was less probable because normally presents in children, and thromboangiitis obliterans too. Considering also this patient had this really smoking history of 20 years, I think Mark said. So later it was revealed that this patient had positive serologies of Hep B and Hep C, and also what inclined the team to get those serologies was that he had mild transaminases elevation. So when we have a patient that has Hep B or Hep C infection, we need to look out for complications of both these diseases. So essentially, polyarteritis nodosa is associated with Hep B, and also essential mixed cryoglobulinemia is associated with Hep C. But this patient had negative serologies for cryoglobulins, and his Hep C testing was a false positive. So even though Hep B is associated with polyarteritis nodosa, idiopathic polyarteritis nodosa is way more common, and those mildly elevated LFTs probably suggest that this patient was more in the idiopathic bucket. So that's everything I have for you, and thank you for your attention, guys.
I can't believe you captured all that, Mariano. That was absolutely superb. I know you're not able to run and stay in shape that way, but I think with the amount of delivery for teaching points, you're keeping your body in cardiovascular fitness. That was absolutely incredible. Thank you so much. Thanks, Mark, for a breathtaking case. Really hope to see you around here in VMR. You definitely have a family here for you. And see you all next time. Bye.